Hello, my name is Glenn Gill, and I will be presenting deep vein thrombosis and pulmonary embolus. Beginning with typical patient presentation, an overweight 50-year-old man who has recently been in a car accident has greatly affected the left side of his leg. He presents to his physician with edema, swelling in his left foot and ankle, and pain in his left calf. He also notes that he feels warmth and tenderness around his calf. Next is the etiology. The etiology of DVT can be divided into two main groups: heredity, which includes factor V Leiden, protein S or C deficiency, antithrombin 3 deficiency, and heterozygous carriers of G20210A. Next, we have the acquired causes, and those include secondary to cancer, pregnancy and puerperium, oral contraceptives, immobilization, long travels, and blood conditions such as thrombocytosis. Some background about DVT. It is estimated that 60,000 to 100,000 Americans die of DVT. 900,000 people could be affected, and 1 to 2 per 1,000 each year in the US. I would like to include the German pathologist Rudolf Virchow, who in the 19th century was one of the first physicians to examine diseases at a cellular level, and this included pathological thrombosis. He described 3 factors, which included venous stasis, venous endothelial injury, and hypercoagulable state. These 3 factors would be known as the triad of Virchow. The following are risk factors for deep vein thrombosis. Beginning with age, being older than 60 increases your risk of DVT, though it can occur at any age. Immobilization longer than 3 days. If your legs remain still for hours, your calf muscles don't get contraction, and muscle contractions normally help blood circulation, so if your muscles don't contract, there's no blood circulation. Pregnancy and postpartum period. Pregnancy increases the pressure in the veins of your pelvis and your legs, so women with an inherited clotting disorder are especially at risk for DVT. The risk of blood clots from pregnancy can continue for up to 6 weeks after you have your baby. Having major surgery in the previous 4 weeks can increase the risk of blood clots. Previous DVT can increase the risk of blood clots. Cancer, some forms of cancer can increase the substances in your blood that can cause your blood to clot. Having thrombocytosis is a risk factor. This is a disorder in where your body produces too many platelets and can cause blood to clot. And then we have protein deficiency C and S, prothrombin 20210A mutation, and factor V Leiden, and these are just mutations that can increase blood clotting in your body. Now I would like to go into the pathophysiology of DVT. Beginning with thrombus, this is a blood clot that remains attached to a vessel wall. A detached thrombus is a thromboembolism. Venous thrombi are more common than arterial thrombi because the flow and pressure are lower in the veins than in the arteries, and DVT occurs almost always in the lower extremity. As I had mentioned in the beginning of my presentation, German pathologist Rudolf Virchow described 3 factors that are very important to the development of venous thrombosis. We have venous stasis, venous endothelial damage, and hypercoagulable state. On my slide, I had forgotten to change it, but it is not a stage. These factors are not stages that occur in any order. Any of these factors, or even all 3 of them at the same time, can be present when you deal with venous thrombosis. That is very important to know. So going into more depth, venous stasis is a result of anything that slows down venous blood flow. This is caused by microthrombi that do not wash away by fluid movement, and thrombi that stays can grow and cause a lot of damage. Next, we have venous endothelial damage, and this is damage in the blood vessel that can be a result of an injury or any surgeries that a person has gone through. And lastly, we have hypercoagulable state, and this is just the increased tendency to develop blood clots or thrombosis due to the presence of factors that can either be caused by heredity or inherited or acquired causes. So now I will be going into great detail about the pathophys of deep vein thrombosis, and we will start with the accumulation of clotting factors and platelets leading to a thrombus, which is a blood clot that remains attached to a vessel wall in the vein, and this is often near the venous valve. Next, we have the inflammation around the thrombus. This may promote platelet aggregation, and then the thrombus will eventually grow. This inflammation will cause pain and redness, and this is because the vein is deep in the leg. When the thrombus creates significant obstruction to the venous blood flow, it increases pressure in the vein behind the clot, and this can lead to edema, which again is excessive fluid in the body's tissue. Some thrombi will dissolve without any treatment. However, untreated DVT is associated with high risk of embolization, and that is when a thrombus detaches and the clot travels up to the lung, and this is eventually called pulmonary embolism, which I will explain in the slides coming up next. And if there's persistent venous obstruction, this leads to chronic venous insufficiency and post-thrombic syndrome that is associated with pain, edema, and ulceration of the affected limb. Pulmonary embolus, as I mentioned in the previous slide, occurs when a blood clot gets lodged up in an artery in the lung and blocking the blood flow to part of the lungs. This is connected to DVT because DVT arises when a thrombus that starts up in the legs travel up to the heart and to the lungs. This rarely originates in the pelvic, renal, or upper extremity veins or right heart chambers, and after traveling to the lungs, large thrombi can lodge at the division of the main pulmonary artery or the lobar branches. So with the pathophys of pulmonary embolus, this can arise anywhere in the body, mostly coming from the calf vein, since that's where a lot of DVT, the thrombus, starts off. Pulmonary embolus has respiratory consequences, and that would include increased alveolar dead space, and this is when there's obstruction of the pulmonary artery by an embolus. This causes increase of alveolar dead space. The increased dead space impairs the elimination of carbon dioxide. Hypoxemia is low levels of oxygen in the blood, and hyperventilation is just when a person is breathing deeper and more rapid than normal. Other consequences would include regional loss of surfactant and pulmonary infarction, and approximately 10% of patients have peripheral occlusion of pulmonary artery, causing parenchymal infarction. How pulmonary embolus is presented: it has an abrupt onset of pleuritic chest pain, shortness of breath, and hypoxia. Patients with pulmonary embolus have atypical symptoms such as seizures, abdominal pain, fever, coughing, and flank pain. Diagnosis of pulmonary embolism would include physical signs of tachypnea, using laboratory tests such as the D-dimer test, using imaging studies such as CTA or MDCTA, which is the criterion standard for diagnosing pulmonary embolus, and anticoagulation and thrombolysis. Now I would like to discuss the symptoms of deep vein thrombosis. Here on this slide I have included my patient presentation from the beginning of my slides. Starting off, it states that the patient is overweight. Being overweight can increase the pressure in your veins and in your pelvis and your legs, and this is what this man has. He has recently been in a car accident, and I would connect that to venous endothelium injury. And certain injuries or surgeries in your leg can be a factor of developing DVT. He presents that he has edema, which is one of the most specific symptoms when dealing with DVT, and that is just the excess fluid trapped in his body's tissues. He has leg pain. This occurs in 75% of most patients, but it's non-specific, and he says that he has leg pain in his left calf. And he also notes that he feels warmth and tenderness, and those are also symptoms of DVT. So now I would like to go into the diagnosis of DVT. So first we have clinical assessments, and this is just the careful evaluations of the patient's signs, symptoms, and if patients are present with DVT, they will be presenting with pain, swelling, tenderness in their leg area. Next, there would be initial objective testing. This would be either venous ultrasonography or D-dimer testing. Ultrasonography of DVT identifies 95% of deep vein thrombosis that occurs in large veins above the knee. It's a very good testing because when the test is positive, there's no further testing necessary, and treatment can be started already. D-dimer testing of DVT is used to help rule out the presence of inappropriate blood clots, which is thrombus, and help diagnose disease and conditions that cause hypercoagulability. Next, there would be follow-up testing, serial ultrasonography or venography. This is further testing indicating if there's a disagreement among the clinical assessments that they have done on the patient. As I had stated before, D-dimer testing of DVT is used to help rule out the presence of inappropriate blood clots and help diagnose disease and conditions that can cause hypercoagulability. Here we have D-dimer tests can be ordered if someone has symptoms of DVT such as leg pain, tenderness, usually in one leg swelling, which is edema, and discoloration of the leg. And to the right, we have D-dimer testing can be ordered for someone who has pulmonary embolism such as sudden shortness of breath, coughing, lung-related chest pain, and rapid heartbeat. Treatments for DVT would be anticoagulation therapy, and this is just to prevent the extension of thrombus or pulmonary embolism in short term and to prevent it from reoccurring in a patient's long-term life. Anticoagulation therapy is used to treat and prevent blood clots that may occur in the blood vessels, and for longer treatment, most patients use oral therapy with vitamin K antagonists, and this is very effective to prevent recurring thrombosis. And below, I just mentioned that a first option would be to introduce low molecular weight heparin as a replacement for unfractionated heparin, and the second is to improve the ability to identify patients who are likely to benefit from longer duration of anticoagulant therapy. Here are my references, and if you have any questions, please leave some comments down below, and thank you for listening to my presentation.